talk about tracheostomy. A tracheostomy is a surgically created stoma or opening, in an anterior portion of the trachea to establish an airway. A tracheostomy may be undertaken to, number 1, establish a patent airway, number 2, bypass an upper airway obstruction, number 3, facilitate removal of secretions, 4, permit long-term mechanical ventilation, or 5, facilitate weaning from a mechanical ventilation. Most surgical tracheostomies are performed in the operating room using general anesthesia. These are typically done electively on patients already intubated who require prolonged mechanical ventilation. When swelling, trauma, or upper airway obstruction prevent endotracheal intubation, an emergent surgical tracheostomy may be performed at the bedside. A minimally invasive percutaneous tracheostomy can also be performed at the bedside using a local anesthesia and some sedation or analgesia. A needle is placed into the trachea, followed by a guided wire. The opening is progressively dilated until it is large enough for insertion of the tracheostomy tube. The tracheostomy tube is shorter in length and slightly wider in diameter than an ET tube, thereby making it easier to keep the tube clean and facilitate better oral and bronchial hygiene. With the use of a tracheostomy in comparison to an ET tube, patient comfort may be increased because no tube is present in the mouth. There is also less risk of long-term damage to vocal cords. A tracheostomy provides a more secure airway and is less likely to be displaced. A variety of tubes are available to meet individual patient needs. All tracheostomy tubes contain a faceplate or flange, which rests on the neck between the clavicles and the outer cannula. In addition, all tubes have an arbitrator, which is used when inserting the tube. During insertion of the tube, the arbitrator is placed inside the outer cannula with its rounded tip protruding from the end of the tube to ease insertion. After insertion, it's immediately removed so that air can flow through the tube. You want to keep the arbitrator at the bedside in case of accidental decannulation. Tracheostomy tubes have an outer cannula, which keeps the airway patent, and an inner cannula, which can be disposable or non-disposable and removed for cleaning. Cuffed and uncuffed tracheostomy tubes are available. A tracheostomy tube with an inflated cuff or a balloon is most commonly used, particularly if the patient needs mechanical ventilation or is at risk for aspiration. Cuffless tubes are primarily used for patients with long-term tracheostomy, making eating and talking possible. Outer and or inner cannula may be fenestrated or non-fenestrated. A fenestrated tube has an opening or a hole on the surface of the tube. A fenestrated tube will allow the patient to breathe spontaneously. If the procedure is being done at the patient's bedside, ensure all appropriate personnel including respiratory therapy, has been notified. Emergency resuscitation equipment, including a bag valve mask, should be readily available. If you are asked to help during the procedure, ensure you place the arbitrator inside the inner cannula with its rounded tip protruding from the end of the tube to ease insertion. After insertion, immediately remove the arbitrator so that air can flow through the tube. Keep the arbitrator in an easy, accessible place at the bedside so that it can be used quickly in case of accidental decannulation. After insertion, immediately remove the arbitrator so air can flow through the tube. Keep the arbitrator in an easily accessible place at the bedside so that it can be used quickly in case of accidental decannulation. Immediately after the procedure, the cuff or the balloon is inflated. The patient's chest is auscultated for air entry. Air entry should be heard in all lung fields. The tracheostomy tube is sutured and secured in place with cotton tracheostomy ties, tracheostomy tapes, or Velcro straps. Here is a picture of a tracheostomy tube. One has the balloon and one does not. So tracheostomy care. If the inner cannula is disposed, replace it as per manufacturer and institutional guidelines. If non-disposable, clean the inner cannula at least every shift. Cleaning removes mucus from the inside of the tube to prevent airway obstruction. If humidification is adequate, mucus may not accumulate, and a tube without an inner cannula can be used. So, the procedure to clean the inner cannula and the stoma. So, step number 1, you're going to explain the procedure to the patient. Step number 2, use the tracheostomy care kit or collect necessary sterile equipment. So, you need a suction catheter, gloves, water basin, drape, tracheostomy ties, a tube brush or pipe cleaners, 4x4 gauze pads, sterile water or normal saline, and a tracheostomy dressing, which is optional. Clean technique rather than sterile technique is used at home. Step number 3, position the patient in semi-Fowler's position. Step number 4, assemble needed materials on bedside table next to the patient. Step number 5, wash your hands, put on goggles, and clean gloves. 6, auscultate chest sounds. If rhonchi or coarse crackles are present, suction the patient if unavailable to cough up secretions. Remove soiled dressing and clean gloves. Step number 7, open sterile equipment. Pour sterile water or normal saline into 2 compartments of the sterile container or 2 basins, and then put on your sterile gloves. Hydrogen peroxide, 3%, is no longer recommended unless an infection is present. If used, the inner cannula and skin must be rinsed with sterile water or normal saline afterwards to prevent trauma to tissue. Step number 8, unlock and remove inner cannula if present. Many trach tubes do not have inner cannulas. Care for these tubes includes all steps except for inner cannula care. Step 9, if disposable inner cannula is used, replace with new cannula. If non-disposable cannula is used, you're going to immerse the inner cannula in sterile solution and clean inside and outside of the cannula using a tube brush or pipe cleaner. Rinse the cannula in sterile solution, remove the solution, and shake to dry. Insert the inner cannula into outer cannula with the curved part downward and lock it into place. Then step number 10, remove dried secretions from stoma using a 4x4 gauze pad soaked in the sterile water or saline. Gently pat the area around the stoma dry. Be sure to clean under the tracheostomy faceplate using cotton swabs to reach this area. Step number 11, maintain position of tracheal retention sutures if it's present by taping above and below the stoma. Step number 12, repeat care 3 times a day and as needed. So changing the ties. Change the tracheostomy tapes after the first 24 hours and then as required. So you're going to, in figure number 1, a slit is cut about 1 inch from the end. The slit end is put into the opening of the cannula. Then B, a loop is made with the other end of the tape. Then C, the tapes are tied together with a double knot on the side of the neck. Then in figure D, a tracheostomy tube holder can be used in place of twill ties to make the tracheostomy tube stabilization more secure. A 2-person technique, one to stabilize the tracheostomy and one to change the ties, is best to ensure that the tracheostomy does not become accidentally dislodged during the procedure. Place 2 fingers underneath the ties to ensure they are not too tight, around the neck. Okay, so when we suction a trach, assess the need for suctioning every 2 hours. Indications include coarse crackles or rhonchi over large airways, moist cough, increase in peak inspiratory pressure on a mechanical ventilator, restlessness or agitation if accompanied by a decrease in the SpO2 level. Do not suction routinely or if a patient is able to clear their secretions with a cough. If suctioning is indicated, explain the procedure to the patient. Next step, collect necessary sterile equipment, which includes the suction catheter, gloves, sterile water, a cup, and drape. If a closed tracheal suction system is used, the catheter is enclosed in a plastic sleeve and reused. Next step, check suction source and regulator. Adjust suction pressure until the dial reads 120 to 150 with tubing occluded. Next step, you're going to assess the SpO2 level and heart rate and rhythm to provide baseline for detecting change during suctioning. Wash hands and put on goggles. Then the next step is use sterile technique to open the package. Fill the cup with sterile water. Put on sterile gloves and connect the catheter to suction tubing. Designate one hand as contaminated for connecting and disconnecting the tubing at the suction catheter using the resuscitation bag and opening the suction control. Suction sterile water through the catheter to test the system. Next step, you're going to provide pre-oxygenation for a minimum of 30 seconds by adjusting the ventilator to deliver 100% O2. You're going to use a reservoir-equipped manual resuscitation bag connected to 100% oxygen, and you're going to ask the patient to take 5 or 6 deep breaths while administering the oxygen. The method, you can do one of those 3 things. The method chosen will depend on the patient's underlying disease and acuity of illness. The patient who has had a tracheostomy for an extended period of time and is not acutely ill may be able to tolerate suctioning without use of an MRB or the ventilator. Next step, gently insert the catheter without suction to minimize the amount of oxygen removed from the lungs. Insert the catheter to the point where the patient coughs. Then you know resistance is met, or about 0.5 to 1 centimeter beyond the length of the artificial airway. Withdraw the catheter about 0.5 to 1 centimeters before applying suction to prevent trauma. Apply suction intermittently while withdrawing the catheter in a rotating manner. If secretion volume is large, apply suction continuously. Suction should be applied for as short amount of time as possible to minimize decreases in arterial oxygenation levels. Limit suction time to 10 seconds. Discontinue suctioning if the heart rate decreases from baseline by 20. Increases by baseline by 40. If you see a dysrhythmia, or if your SpO2 level decreases to less than 90%. After each suction pass, oxygenate for at least 30 seconds with 5 to 6 breaths by ventilator, MRB, or deep breaths with oxygen. Next, rinse the catheter with sterile water between suction passes. Next, you're going to repeat the procedure until airway is clear. Limit insertions of suction catheter to as few as needed. If the airway is not clear after 3 suction passes, allow the patient to rest before additional suctioning. Return oxygen concentration to prior setting. Then you're going to rinse the catheter and suction the oropharynx or use mouth suction. Dispose of the catheter by wrapping it around your fingers of the gloved hand and pulling the glove over the catheter. Discard the equipment in the proper waste container. Then finally, you'll auscultate to assess changes in lung sounds. Record time, amount, and character of secretions in response to the suctioning. If a patient is on a ventilator, the use of a closed system suction catheter is preferred in order to minimize breaks in the system and decrease the risk of ventilator-associated pneumonia. Non-sterile gloves are worn during the suctioning procedure as sterility of the suction catheter is maintained with a closed system. Both cuffed and uncuffed tracheostomy tubes are available. A tracheostomy tube with an inflated cuff is used if the patient is at risk for aspiration or needs mechanical ventilation. Because an inflated cuff exerts pressure on the tracheal mucosa, it's important to inflate the cuff with minimum volume of air required to obtain an airway seal. Cuff inflation pressure can be measured with a handheld cuff manometer. The pressure should be monitored at least every 8 hours. Cuff inflation pressure should not exceed 20 to 25 centimeters. Because higher pressures may compress tracheal capillaries, limit blood flow, and predispose to tracheal necrosis. The maximum leak technique and the minimal occlusion volume are two commonly used methods to inflate the tracheostomy cuff. Routine cuff deflation is no longer recommended. Retention sutures may be placed on the tracheal cartilage when the tracheostomy is performed. If present, tape the free ends of the skin in a place and manner that leaves them accessible if the tube is dislodged. Take care not to dislodge the tracheostomy tube during the first 5 to 7 days when the stoma is not mature or healed. Because tube replacement is difficult, several precautions are required. You have to keep a replacement tube of equal or smaller size at the bedside, readily available for emergency reinsertion. Do not change tracheostomy tapes for at least 24 hours after the insertion procedure. A physician performs the first tube change usually no sooner than 7 days after the tracheostomy. If the tube is accidentally dislodged, immediately call for help. While waiting for the healthcare provider, a respiratory therapist, or other designated individual to arrive, several options may be used depending on nursing scope of practice and hospital policies and procedures. Quickly obtain a hemostat to spread the opening of the opening where the tube was displaced. Insert the arbitrator in the replacement or the spare tracheostomy tube that you have there at the bedside. Lubricate with saline and insert the tube into the stoma. Once the tube is inserted, remove the arbitrator immediately so that air can flow through the tube. Insert a suction catheter to allow passage of air and to serve as a guide for insertion. Thread the tracheostomy tube over the catheter and remove the suction catheter. If the tube cannot be replaced, assess the level of respiratory distress. Position the patient in semi-Fowler's position to alleviate difficulty of breathing. Until assistance arrives. Severe difficulty of breathing may progress to respiratory distress. If this situation occurs, cover the stoma with sterile dressing and ventilate the patient with bag mask ventilation over the nose and mouth until help arrives. If a patient has had a total laryngectomy, there will be a complete separation between the upper airway and the trachea. Ventilate this patient through the tracheostomy stoma. Removal of the tracheostomy from the trachea is known as decannulation. Removal is possible when the primary condition for which the patient initially received a tracheostomy has been resolved. In addition, the patient needs to be hemodynamically stable. They also have to have a stable, intact respiratory drive, and they must adequately exchange air and be able to cough up secretions. Post-decannulation care involves application of sterile occlusive dressing and monitoring the site for bleeding. The dressing must be changed if it gets soiled or wet. If necessary, close the stoma with tape strips. Epithelial tissue begins to form in 24 to 48 hours and the opening will close within 4 to 5 days. Surgical intervention to close the tracheostomy is not required. Monitor the patient's respiratory status and oxygen saturation for any evidence of air compromise. Apply an alternate method of oxygen delivery if required. Instruct the patient to splint the stoma with fingers when coughing, swallowing, and speaking.